Hello, my name is Michelle Morand. I'm a precision cancer medicine educator and advocate, and I'm here with Alexander Rolland, oncogenomics expert, and we're going to share some information with you today about how to make sure you are making the best of the most current science. And we're going to do that kind of in reverse by talking about a recent broadcast that Alex is going to share with you, in which oncologists were making some claims that really the science doesn't back up. And we want you to be really well educated. So here we are. Alex, take it away.
Yeah, so this is based on a story I watched on CBC's National News. I always watch the national news. I'm a true Canadian. I love the national news, and I've always watched it. And I make sure I catch the 6 o'clock. I think it's a great, unbiased approach, and I love CBC. Anyways, in this particular story, it featured a group of Canadian oncologists who were promoting the concept that stopping late-stage cancer treatments with drugs that are ineffective and costly should be an important consideration. And while I wholeheartedly agree with that, my concern is really how determining if a drug is ineffective was made. I think there was some real mistakes there. And in this particular case, they focused on a drug that they said was expensive and less effective than standard care. So we're going to go over that in detail. But also in this report, they focused on a patient who decided to forego further treatment for his late-stage cancer. And the emphasis was that by doing so, the patient was able to live his final days in the moment, so to speak. And importantly, that just trying to find new life-extending treatments to buy more time could have the effect of stressing patients out and preventing them from enjoying their final days. And of course, they also focused on the negative side effects of these drugs. They used a new drug, a new targeted therapy as a surrogate for their concept. And while this emphasis on stopping treatments to improve the quality of life is an important consideration, and the discussion centered around the patients settling for having this conversation with their medical oncologist alone. I completely disagree with this. Medical oncologists are not trained in modern science or genetics. They have enough enough work doing their regular duties of understanding how patients are responding to a drug and making sure the patients are healthy enough and all of the other things that medical doctors do. Determining which drug and how to use the drug, I think, is really the domain of science, and I think it should be left there.
It's also important to note that, statistically, only 20% of physicians say that they have even moderate confidence in how and when to use genetics to inform patient care. Medical oncologists the whole field arose about how to administer and monitor chemotherapy. We have to respect what these doctors are capable of and know how to do. But when it comes to the use of genomic information and the most current treatments, the education has not kept up with the science. And that's really what this report shows.
Yeah, and there's no possible way it could. It's a completely new independent discipline.
Yeah.
We need a whole new discipline here to connect science to the MDs.
Yeah. So really what Alex is sharing essentially is kind of a good example of how when well-intended, knowledgeable professionals are trying to make sense of something that they don't necessarily have a full training around or a full grasp of, it's easy to misunderstand data and then misrepresent this data to the patients on the front lines. And that's what we're here to try to make sure doesn't happen.
Yeah, and let's not forget, right now, Canada is experiencing a real desperate situation in its medical system. Not to mention, Canada is ranked by the World Health Organization as 23 out of 28 countries in public healthcare based on the quality of our diagnostics for cancer. So, we're struggling as it is. This extra burden on doctors alone is really not a good idea.
Yeah, so there are options. The point is there's lots of ways of getting more accurate diagnostics and better treatment options. And really today we're just going to talk about some of the common barriers that come up using one specific example.
Yeah, and precision oncology, which is what we promote and do, is the right drug at the right time for the right patient. And that there's many things to consider when you're trying to determine these factors.
Yeah.
And so we always recommend, seek multiple independent opinions and don't go with an opinion. An opinion is a personal conclusion. Go with science. Go with peer-reviewed data and science. Always use advanced molecular diagnostics, such as tumor DNA, RNA, to identify drivers for targeted therapies. And importantly, always use accurate assessments of staging, such as PET CTs, which are designed for cancer. But instead, this report focused on encouraging patients to rely on their oncologist and their local of standard of care. And we know that it's not possible to get the same standard of care across all of Canada and across all of North America and across all international boundaries. Medical care and the standard of care greatly differs depending on where you go. And of course, the quality of the hospital and, the country you live in.
But the point is, if you know what to ask for and how to advocate well for yourself, you can really improve the types of treatments that you're able to access and the outcome.
Most definitely. Knowledge is power.
Yeah. I think that's why we want to make this video, isn't it, Alex?
Yes,
is because
it is.
the implication is, don't worry about it. Just listen to your doctor and just accept your fate. And no.
Listen to many doctors, listen to many scientists, and read journals. Educate yourself. Yes. So, if patients are being forced to make life-altering decisions, we believe the emphasis should really be on the patients having rapid access to more thorough and accurate information and not going with personal opinions. And so, the fact that there's a group of doctors that seem to think that cancer patients should just accept their fate and that their only decision is between palliative chemo or no care at all is just ridiculous. We strongly do not agree with this approach.
And again, just to be clear, the reason that we have this strong opinion is because these patients that we're talking about, or even the example provided in this the news story, this particular individual was not provided with a thorough genetic assessment of their cancer. If that has been done and then all of the options have been exhausted, that's one thing, and we empathize and we're in support then. But this is the point.
Yes.
It's not done.
So let's go over the case that they use as an example. In this particular case, they used this new drug that is called sotorasib. And they promoted it as saying, this drug study, when it came out, was big news. However, what they failed to state was the reason why this drug was big news. This drug was big news because it targeted something called a KRAS G12C mutation. So forever, KRAS has been considered an undruggable gene. And it is one of the most common genes that is altered in cancer. So many cancers have altered KRAS. And we have tried for a long time to target this particular gene, but it's very hard to drug. Very hard to target. So having a drug that targets even one KRAS G12, even one KRAS mutation was really the big deal about this drug, not necessarily the drug itself. And this drug was just the first generation of a class of drugs that is going to really change cancer treatment.
And there are more of these now.
Talk about that. Yes. Yeah. So this particular, additionally, this particular mutation, KRAS G12C, which refers to a mutation in the KRAS gene of a G, which is a guanine, at the 12th codon to a C, cytosine, is a mutation that causes this gene to stay stuck on and causes constitutive signaling. In other words, this gene, when it's altered like this, basically tells the cell to constantly grow and divide. It's not that common. It's in about 11% of non-small cell lung cancers. But for those cancer patients that have that mutation, as discovered by tumor DNA sequencing, having a drug that targets that mutation can be a game changer. And we want to emphasize how this trial was looked at. So additionally, other targetable mutations exist in patients with KRAS G12 mutated non-small cell lung cancers. We've seen HER2 mutations that are targetable. We've seen PIK3CA mutations. We've seen ALK mutations, NTRK mutations. We've seen all kinds of other mutations in patients with this. So it's not the only targeted mutation that could possibly exist in the patient with non-small cell lung cancer. So in this particular report, they claimed that the overall survival for sotorasib was 10.6 months versus 11.3 months for docetaxel. And of course, the cost difference. Now, obviously, this is a new drug at the time. The cost has gone down substantially, and there are newer versions of the drug, and there will be some generic versions of it too, which will be much cheaper. So the important thing is they use this. And so, here's a drug that is a targeted therapy for patients with KRAS G12C mutated non-small cell lung cancers, and it didn't perform as well as the docetaxel. So why use it?
Is what they're saying.
Yes, that's what they're saying.
Right. Yeah.
So, why would we use this drug? It's not even, it's not even as effective. So the reality is, though, is if they actually had looked over the report and read it, and not just read the headlines, which is the median overall survival, they would have seen that twice as many patients responded to sotorasib than docetaxel. In other words, out of 100%, twice as many patients responded. Also, the response time, in other words, getting the benefit from the drug, was twice as fast with the sotorasib than docetaxel. And also, the grade 3 side effects, which are referred to as adverse events, were more frequent with docetaxel than with sotorasib. And last but not least, the important thing when you're considering common sense oncology is at 12 months, 24% or almost 25% of the patients were still responding to sotorasib versus only 10.1% for docetaxel. So you got to read these studies. You can't just read the headline or read the abstract. You need to look at the data when you're making these conclusions. And clearly, the doctors and the CBC reporter who were involved in this did not do that. So let's just talk about this. We're going to go into some details here. Once again, while the overall survival data and initial cost of the drug shared in this report were accurate, and based on the recent CODEBREAK 200 study, the conclusions about this study were not. And so sadly, this presentation of this data is very misleading, and especially in the context of what is truly common sense oncology. And this really speaks to the importance of accurate peer-reviewed data analysis. In other words, the statistics they are referencing in their ultimate conclusions do not reflect the actual results of the study and are a poor way of deciding whether this drug is beneficial for patients in the context of truly common sense oncology. They did not share that information. And they did not share that this was this was just the start of targeting KRAS G12C, and that there is a much more effective drug called adagrasib now available, thanks to the work that was done with sotorasib. In other words, they used one drug, not even the best for that mutation, that targets an uncommon mutation, and they did not properly present the data about the results. Why not present some of these amazing results from all these other studies, such as the NETTER-2 trial that just came out? There's so many great results in precision oncology. And so, why not present some of that? They must have really scraped the barrel for this study. To be fair, though, this is unintentional, I'm sure, just lack of understanding, but that's kind of the point. If you have an oncologist or, they're not molecular genetic specialists, and clearly they're not science-based either in this sense, and they're not precision cancer medicine specialists. So they need to adopt that to their group. If they're going to be making these conclusions, they need to adopt some scientists in their group to help them understand this data. And so to take this massive leap to suggest that this one example is why precision cancer medicine is not worth exploring for late-stage cancer patients is just ridiculous. So a bit about us. We have 14 years of experience helping cancer late-stage patients access these treatments. We've seen some incredible results, and we really believe that it's critical that cancer patients know about all of their options internationally so that they can make those decisions. You can't make a proper decision if you do not have all of your possible treatment options. And when I say treatment options, let's start with understanding what has the potential to work for you. What are the benefits and disadvantages of it? And then you can seek out how to access it, because accessing these drugs is much less of a problem than figuring out what is beneficial and what is not. Mm-hmm. So let's look at this CODEBREAK study and just see exactly what went wrong. So this study was for locally advanced unresectable or metastatic KRAS G12C non-small cell lung cancer patients who underwent prior treatment with either a platinum chemotherapy drug and checkpoint inhibitors, which is pretty standard for KRAS mutated non-small cell lung cancers these days. And that's a new standard of care. It hasn't been around for that long, immune therapy plus chemo. And so these patients were randomized to receive either sotorasib or docetaxel. So here's a little bit of a history of the CODEBREAK studies of sotorasib leading up to it. And as you can see, it's what's important to look at is the statistics. So the drug sotorasib in the CODEBREAK 100, second study, and then of course a phase 3 study where they use it with sotorasib versus docetaxel. So as you can see, the response rate, how many patients out of 100 percentage is a percentage respond to the drug. The first study was 32.2%, then it went up to 37.1%, and then in the CODEBREAK 200, which was later stage patients, it was 28.1%. However, docetaxel was only 13.2%. So only 13 patients responded to docetaxel, whereas 28 responded to sotorasib. And importantly, as you can see, the duration of responses was 8.36 months versus only 6.8 for docetaxel. And here you can see the glaring difference in overall survival, which is 10.6 months versus 11.3 months for docetaxel. So in this statistic, overall survival, docetaxel beat out sotorasib, but we're going to talk about that. And here's a crystal study that talks about adagrasib, which is the new version. It's a better version of sotorasib. You can see a 43% response rate right away, 12.6 month overall survival. So we're going to see good things from adagrasib, and that is my drug of choice if someone has a KRAS G12C altered cancer. Mm-hmm. One of the biggest issues, as we discussed, is people do read the abstracts and they don't read the studies. They don't actually go into it and look at the statistics. One of the biggest problems I see is they don't look at separation of progression-free survival curves or survival curves, and I'll explain that in details. So point one, in this report, they focused on the overall survival. And so they showed that it was obviously inferior compared to docetaxel. However, it's important you understand what the overall survival is. So the overall survival rate, so we have three statistics that are pretty important in cancer. We have the overall response rate, and that refers to how many patients actually got a response to that drug. The response can be a complete response, it's based on something called the RECIST criteria for solid tumors. It can be a complete response where, it's self-explanatory, all of the tumors, we're talking metastatic patients, all of the tumors disappear. Or a partial response, some of the tumors disappear, some don't, or stable disease, where the tumors don't grow, but they don't shrink either. So, all three of those are going to be beneficial to someone with cancer. But what the overall survival and the progression-free survival, these are statistics that were derived to allow a doctor to say, you have a pretty good chance of achieving this statistic. They are what are referred to as medians. So the overall survival is when 50% of the patients in the trial die from the drug. So it's a time period. So let's say a bunch of patients start taking the drug, and then at 10.6 months, 50% of those patients on that drug die. Then that is the overall survival. The progression-free survival is a similar statistic, but it refers to how long the patients remain cancer-free rather than die. But once again, the important thing is these are medians, and a median is only 50% of the patients. So some of those patients may have died earlier, and some of those patients may have gone on to live much longer. So when you have this, then the doctor can turn around and say, well, you have a 50% chance of this drug giving you 10.6 months, for example. And so that's a nice statistic that they like to toss around, but it is not that accurate in looking at the context of what we call common sense oncology. So remember, this discussion in this report was about quality of life, yet they focused on this statistic of overall survival. However, the important thing, this trial was not designed or powered to determine overall survival. That's a very important point. And I'll explain why. Clinical trials for cancer patients need to be ethical. They need to consider the patient and not just be about statistical data. So obviously, what they do is they have these things called crossovers. In other words, patients who are not responding to a certain drug can cross over to a drug that they do respond to. So in this particular study, 34% of the patients in the docetaxel group, which is the standard care, received a KRAS G12C inhibitor. And remember, they have a longer survival in the docetaxel group, but 34% of them, over 1/3 received the KRAS G12 inhibitor. And 26% of those patients crossed over to receive sotorasib.
So the point is, at least 1/3 of the folks in that docetaxel group actually did get some targeted therapy, not just the chemo.
Yes. In other words, patients who could not tolerate, who did not respond to docetaxel, remember it has worse side effects, were artificially removed from the statistics for docetaxel and added to the sotorasib.
Oh, that's critical info.
Now, often in these studies, they alter the statistics for that, and they compensate for that. But this was not acknowledged in the report on CBC. But even if adjusted for statistically, these stage 4 patients could have been very sick and unlikely to even respond to sotorasib at this point. But now they're being added to that group. And then the overall response rate, which is an important consideration. The overall response rate is a statistic that indicates how many patients out of 100% respond to the drug. Once again, I explained the RECIST criteria of responses: complete response, CR, partial response, PR, or stable disease. An overall response rate includes all 3 responses combined together. In this trial, over double the amount of patients responded to sotorasib than did docetaxel. Double. That is a consideration alone for common sense oncology. And importantly, sotorasib had a much quicker time to response, 1.4 months versus 2.8 months on docetaxel. So almost double the time before the patient started feeling better. That is an important consideration for common sense oncology. So also patient stratification. Precision oncology, once again, is the right drug for the right patient at the right time. One of the most important things that we've been doing in the last, 4 or 5 years is not just looking at drugs that indicate whether you have a targetable mutation, but whether you have a co-mutation that affects your response to that drug. And there is tons of data on this. Just about every mutation that has a targeted drug has numerous peer-reviewed studies that show co-mutations that can interfere with that drug or improve the efficiency of it. And every single targeted therapy we've looked at has these co-mutations that can really determine whether the patient responds properly. So basically, a co-mutation is a DNA mutation that can prevent a specific targeted drug from working. They can occur in the same gene being targeted, such as KRAS, or in other genes. So in a recent molecular analysis, it showed that patients with mutations in a gene called KEAP1 and STK11, if they had mutations in those genes, then they had a reduced benefit with the sotorasib. So that would be an important consideration. So if you're doing tumor DNA sequencing and you identify a KRAS G12C mutation, then you want to be doing a tumor DNA sequencing panel that looks at all of the mutations, or as many mutations as you can, not a targeted spot panel, because then you can look at the KEAP1 and the STK11. Now, these mutations are covered in just about every tumor DNA sequencing panel I use that is not a spot panel. All of the big panels cover this. And so this is just another reason why you need to get a proper tumor DNA sequencing panel of anywhere from 300 to 600 genes in this day and age, and not a spot panel that just only looks at a fraction of mutations. So in this study, in this analysis, only 14% of patients with the KEAP1 co-mutation responded to sotorasib. Now, remember, the response rate for sotorasib in this CODEBREAK trial was much higher than that. And 23% of patients with STK11 and KEAP1 co-mutations responded to the drug. So you're going to want to look at this. So if you're going to be doing common sense oncology, then you're going to want to know, does your patient have a KEAP1 or STK11 mutation before you even consider sotorasib? And so once again, this lack of patient stratification is an important consideration. So these desensitizing mutations, as I like to call them, which are typically covered in multi-gene tumor DNA sequencing panels, but not spot panels, need to be considered. So, importantly, in this study, the CODEBREAK, when you look at the data, 37.5% of patients in the CODEBREAK study that we're talking about had a STK11 mutation, and 25.9% had a KEAP1 mutation. So obviously, the patients in this group would have automatically had a reduced response to sotorasib, and that needs to be emphasized. So I put the study down there by Zhang et al., which is a bit of an analysis. There's many analyses on this study. So adverse events, side effects, very important thing. I would say that, if you're going to be talking about common sense oncology, then side effects need to be upfront. And they're referred to as adverse events. And they typically go from grades 1 to 4. Obviously, grades 1 and 2 are, irritating, diarrhea, rashes, and so on. And grades 2 to 4 can be much more serious and require, stopping the drug or, hospital interventions, neutropenia. So in this trial, sotorasib had less grade 3 or higher adverse events, 33.1% compared to docetaxel. So, important consideration right down there. For sotorasib, the adverse events were diarrhea, 12%, increased alanine aminotransferase, 8%, and increased aspartate aminotransferase, which is 5%, and nausea. For docetaxel, they were neutropenia, which, and I highlight neutropenia, and there's fatigue, 6%, and then febrile neutropenia. So what neutropenia is it's a lowering of the white blood cells, neutrophils and so on. And this causes you to become, basically it represses your immune system. So one of the important considerations for patients when they're stage 4, and we're talking older patients typically, they want to spend time around their kids. They want to spend time around their grandkids. And quality of life is really important for people on these drugs. And so if you have a choice between a drug that is going to prevent you or create great risk at you seeing your children, I mean, let's face it, children are little disease carriers. They carry all kinds of diseases. They have runny noses. They run around. So if you have neutropenia or febrile neutropenia, you're probably going to want to restrict who you're around. And you're probably not going to be able to see your grandkids or your children because you're at risk of catching pneumonia or some other life-altering, viral or bacterial infection. And so when we're talking common sense oncology, the type of adverse events you have are very important to consider. And so for docetaxel, having a higher percentage of neutropenia and febrile neutropenia that could prevent you from seeing your grandkids is an important consideration for common sense oncology. Also, serious treatment-related adverse events occurred in 11% of sotorasib recipients versus 23% for docetaxel. Very important. These treatment-related adverse events occurred in one patient in the sotorasib group, which is interstitial lung disease, which is not uncommon in non-small cell lung cancers, and in 2 patients in the docetaxel group, which was ileus and multi-organ failure. So, I know already just from looking at these data, if I was in that stage, I know which drug I would choose. And it would be sotorasib, hands down, for quality of life. And let's move on. We called it the duration of response, the time being cancer-free, was longer for sotorasib. 8.36 versus 6.8 months, 2 months, and most importantly, patients achieved this response much quicker. In other words, the patients on sotorasib had a quicker time to response, 1.4 months versus 2.8 months with docetaxel. When you're dealing, with a time of being cancer-free of, 8 months, a little over 8 months, the difference between 1.4 months and 2.8 months, is double. To getting to that point is pretty important. You need to consider this. And additionally, they also found that time to deterioration, once the patient stopped responding to the drug, cough, physical functioning, global health status, was longer in patients receiving sotorasib compared to patients who received docetaxel. Once again, progression-free survival, as I explained earlier, is the amount of time 50% of the patients in the trial remain cancer-free. However, let's look at the long-term curves, and the same with overall survival. In this case, the overall survival, because of the way the trial was powered and because of the crossover, did not look better. So we don't need to look at the overall survival, but we do need to look at the progression-free survival because that's what this study was powered for. And remember, they're the median, it's only 50%. So what we have here is the progression-free survival. And this is the long-term data. Each little slash represents a patient. So as you can see, each one of these little slashes. And then we have the months on the drug, and then we have the patients that are still progression-free. So if you look at the median, that's the 50% mark. If you go right across here, you'll see right here, this is a median right here for these two drugs. The top blue line is sotorasib, the bottom line is docetaxel. So as you can see, the progression-free survival at 50% is here and here for sotorasib. However, what you do notice is as time goes on, you see a significant separation of these curves. In other words, at 50% of the time, these lines are pretty close together. But as time progressed, you see people in sotorasib remained cancer-free or responding to treatment at a much higher rate. So in other words, at 24 months here, you can see this, or sorry, 12 months, not 24, 12 months, you can see that 24.8% of the patients on sotorasib are still responding to the drug and cancer, well, and still they're still progression free, whereas only 10.1% of the docetaxel patients, and that's even with crossover,
Yeah.
were responding. So over twice as many patients responding at this time period, and this goes right down and continues up until the 19-month mark here, and then of course the two lines flatten out, and there's only like 1, 2, 3, 4 patients at this time period here. So right away, looking at the progression-free survival as a median is very misleading. And often we see this with overall survival. Now, in this particular study, because it was not powered for overall survival, and we had the crossover group, the overall survival is not worth looking at in this particular study. And that's because it wasn't powered and we had the crossover. But the progression-free survival was powered for in this study. And if you look at the long-term here, I mean, I went through this with a study for biliary tract cancer many months ago, a couple of years ago, where I actually had oncologists saying, oh, well, why would you want to do this extra immune therapy drug? It's called the Topaz-1 study that added immune therapy drug to the standard chemo. And when you looked at the long-term overall survival, it was a very similar process. You saw, at 50%, the overall survival was very close for both drugs or both approaches. And then if you looked at the long-term survival, it really, the curves really separated, and a lot more people were alive further down the road on this combination. So I always stress, do not go with the medians. You want to go with the actual long-term data. As you can see, 12 months, number of patients still responding to drugs, 24.8% for sotorasib versus 10.1% for docetaxel. This was totally not covered in the CBC documentary or the CBC report. And this is something that should be a very serious consideration for anybody who is calling themselves a common sense oncologist. So the cost of the drug, this was when the drug first came out. Obviously, the cost is going to be high. They're trying to recoup their money. It can take, 1.5, $1 to $2 billion to bring a drug to trial. But there are many ways of getting these drugs. And, you know, a large part of the time, we're able to get drugs, these new drugs that are just recently FDA approved. We're able to get them for Canadian patients for free from the drug companies because they want to get their drug out there. They want to show everyone how great their drug is. And, you know, we've gotten many patients free drugs in Canada before they were actually available in Canada. So you can get them for free through these drug programs or greatly reduced prices by our pharmaceutical companies, compassionate access. So before you actually claim that you have to pay this for a drug, look at all options. There's also international pharmacies. And when I looked at one international pharmacy, you know, these are just different prices for the same drug in different countries. And like anything, any commodity, drug, anything, prices are going to vary greatly from country to country. So international pharmacies, there's one in Holland that had this drug, I think, for about 14,000 US. So, you know, prices do vary. So the reality, once again, twice as many patients responded to sotorasib than to docetaxel. The response time was much quicker, twice as fast with sotorasib. People started feeling better right away, or almost right away, 1.5 months versus 3 months of docetaxel. The grade 3 side effects, more frequent docetaxel, 23% with sotorasib. And last but not least, the duration of responses was significantly longer with sotorasib. Once again, this is, sorry, not duration of responses, progression-free survival. So at 12 months, well, yeah, it is duration of responses similar. At 12 months, 24.8% of the patients were still responding to sotorasib, even with the crossover of what was it, 26% of patients from the docetaxel group not being able to respond to docetaxel or not tolerating docetaxel being put onto sotorasib versus only 10% for docetaxel. You know, common sense oncology, which drug would you go for? I think hands down it would be sotorasib.
Particularly because you know, if this in this report, Common Sense Oncology is really determined as a true assessment of quality of life for the patient.
Yeah.
So I think what you've shown here in just this comparison, and again, this is kind of the first attempt at a targeted therapy for just one KRAS mutation.
Yeah.
There are multiple, and then there are multiple different genes that are involved in cancer that can be tested for, and many different targeted therapies for those. So this is kind of like not a great example in the sense that it's for a very small percentage of the population. And again, they're using the example of the cost when it first came out as opposed to what it could truly be accessed for. But ultimately, in the end, what we're seeing is the numbers that they chose to show you, the viewer at home, to suggest that you really shouldn't try to find other options beyond standard of care. That's not an accurate representation of the results of this study for just this one drug, let alone many hundreds of different types of targeted therapy for many different mutations that can be tested for and can give you far superior outcomes to this particular drug.
Yeah, and so, you know, in this definition, common sense is only common sense when all options have been reviewed and the patient has been given accurate information of all beneficial options. However, the Canadian medical system does not provide molecular analysis. They don't even do tumor DNA sequencing for most patients.
No.
A perfect example is breast cancer. We have a drug that targets the PIK3CA alteration. You know, up to 40–50% of women with ER-positive lobular breast cancer have PIK3CA mutations. This mutation can also make patients resistant to standard care, chemo. And it is a mutation that definitely has a negative prognosis in many circumstances. But we have a drug for it, alpelisib. It's covered by the Canadian healthcare system. It's been here for almost 2 years. I know that because we were the first to use it. And when I spoke with the drug the drug provider, he said that he's been trying for years to get this drug into Canada. However, how would you know if it's going to benefit you? Because I don't know of any Canadian oncologists that actually do tumor DNA sequencing for their patients. If you don't do tumor DNA sequencing for breast cancer patients, how are you going to know if you have a PIK3CA mutation? How are you going to know if standard care is going to have a worse response for you? How are you going to know if this drug that is approved by Health Canada is going to work for you. So what's the point of having these approved drugs if you're not even testing to see which patients can use them?
Mhm.
I
Yeah.
mean, another example, capivasertib. That's been FDA approved since I think November of last year. Nobody tests for PTEN deletions or AKT mutations or PIK3CA mutations in estrogen positive breast cancer. But this drug is a valuable option when combined with fulvestrant in patients that have become metastatic after CDK4/6 inhibitors. I could go on for hours,
Yes, you could.
but
Yeah.
let's just face it. Common sense oncology, as suggested by these doctors, is not in fact common sense,
No, it's more of a
especially when the most thorough and accurate information of all their options is not provided to the patient.
yeah.
Turns my stomach, to be honest.
Yeah, it's really the reason why we're here.
Yes.
Because if thorough molecular assessment of your tumor has been done, and if the most beneficial targeted therapies have been applied to your care, and at some point down the road, you're out of options, you're out of options. But that's not what's being done in standard of care right now. And
Yeah.
so really what is being advocated for is just don't bother trying to find
Mhm.
other options and just
I
accept
heard
fate.
one of the doctors in the Common Sense Oncology group actually said, oh, many of my patients say, oh, there's all these different drugs offered for my type of cancer in the States. He says, but I tell these patients, these drugs are not going to help you at all. I couldn't believe that. I could not believe that.
Yeah, and that's very, very
I
common.
was just shell shocked from that.
Yeah, it's shocking. So fundamentally, that's why we made this video, folks, is because this is just one example of how doctors might misunderstand, let alone misrepresent your options. We get calls all day, every day from people whose doctors have said they have no markers for cancer, which is not possible, that they're not a candidate for certain treatments, which is not true. And again, the main issue here is just there's so much information. The science of cancer care is changing so rapidly. Medical oncologists have not been properly educated in the reading of genetic testing data, let alone the analysis and the identification of treatment options. And we also have to really acknowledge that even if these doctors really wanted to be that educated and understand these things,
Yeah.
the caseloads that they are expected to manage do not allow them the time. You guys know you're on the front lines as cancer patients, so you get 10 to 15 minutes with your doctor. If you're lucky, they don't have time to do any independent analysis for you. And lastly, the cancer agency that your oncologist works at dictates essentially what they do. Unless you provide your doctor and your cancer agency with better diagnostics that they can provide you and a more accurate assessment of your treatment options, you are hooped. You are stuck with what they will provide you in the way of diagnostics and what they insist you have as a first, second, third line of care. So it really is right now critical that you kind of take matters into your own hands to enhance your diagnosis with more thorough molecular analysis, that's genetic testing, and ideally a PET CT scan, depending on your type of cancer. And there are, of course, very specific details that would determine which tests are most beneficial for you. But that's really what Alex and his team are here for, to make sure that you have that information and you have the support you need to get the right treatment for you. And yes, if years down the road you've exhausted all your options, then of course you will know that, and you will have a level of peace that you really did your best.
And that level of peace is based on knowing you've done everything you can.
Yeah.
No one wants to die with regrets.
No, and we don't want to leave any stones unturned.
No, exactly.
So anyway, hopefully this has been helpful to you in understanding a little bit about how to read some of these studies, for example, the things to pay attention, that progression-free survival and the side effects are two very important details that you will always want to double check if your doctor is saying, no, that's not good for you, or the side effects are not great. Compare that data to what they are recommending and just make sure that you're not being misinformed in the way that folks were with this presentation on the CBC.
Yeah.
Yeah.
And there's a reference for the sotorasib CODEBREAK study.
Yeah, we have lots of options to help you folks. There's a 1-hour face-to-face consultation with Alex and his team, with thorough review of your current medical history, all your treatment options, and a discussion of those with you. We have a free online educational program with live weekly Zooms. You can pop in, educate yourself, ask lots of questions of us. And we have a YouTube channel. All the links are right there for you. And feel free to just reach out anytime to us. Send us your questions. Let us know what you're up against and how we can help you. And of course, tell us what's working for you. We don't know everything, but we do know a lot. And we do definitely know how to find out what matters most. Thanks for watching.
Thank you.